happens here in the ovary is, remember, cholesterol then becomes an androgen. And this happens through LH. So LH makes androgens in the theca cell. The ovary has two sides. So this is why in PCOS you've got elevated androgens and you've got elevated LH. And remember, the androgens cause more LH, so it's a vicious cycle. And then the testosterone diffuses across into a neighboring cell called the granulosa cell, and that androgen then becomes an estrogen. So this is, for those of you that have either are OBGYNs or took an interest in menstrual cycle, this is how the connection between LH and FSH. Right? So they're both needed. LH produces the androgen. And remember I said the takeaway here, you can't make estrogen unless it comes from an androgen. You can't make estrogen unless it comes from an androgen. So that means even in the ovary produces androgens so that they can then be turned into estrogens. And that happens. So this is where that steroid pathway comes to light in the ovary. It makes an androgen, which is then converted through the enzyme aromatase into estrogen. So what if you have something that increases aromatase activity, like inflammation? Ooh, wow. So inflammation increases aromatase. Do you think that means that inflammation might lead to higher estrogen levels? Absolutely. Or that insulin affects aromatase? So if insulin affects aromatase, it would stand to say that women that have elevated insulin have more estrogen, and maybe that elevated women, or that women that have increased insulin, it stimulates aromatase, more estrogen, that they're more likely to have fibroids, or endometriosis, or even breast cancer. And that's all true. That's all true. You actually have aromatase enzymes inside fibroids. So the fibroids grow, and if there's insulin in the blood, or there's pro-inflammatory prostaglandins, that causes the fibroids to grow. So again, in the ovary, androgens form estrogens. I'm just showing you this so many times, you're going to see that again this afternoon. Estrogen dominance, when there's too much estrogen relative to progesterone. We see this. You'll hear all about it this afternoon. Androgens. So now let's talk about PTSD. Production, transport, sensitivity, and detoxification. This is our hormone mnemonic. And the purpose of this mnemonic is to help you figure out what you can do before you give hormone. So we are not against giving hormone. What we are really for, and what we recommend, is trying to create balances in the matrix so that you can then optimize production and transport and sensitivity and improve detoxification, such that if you're going to give hormone when you start, you either don't need to do it anymore or you can give less. That's what we mean when we say treat the matrix before addressing hormone dysfunction, because we have to unlock or treat all the nodes in order to open the vault. The endocrine system is so complex it will autocorrect when other imbalances are addressed. Hormone imbalance is often the appropriate response to imbalances elsewhere. That's why treating root cause or treating other imbalances addresses the hormonal issue. That's what I said about cell membranes that are too rigid and elevated insulin, and why giving omega-3s to create flexible cell membranes that were more fluid, can help with insulin resistance, decreasing inflammation. So do the matrix first. And those are the different locks. And so you then open the matrix, and then when we're in the communication node, we treat in a specific order. Adrenal, thyroid, and then sex steroids. This is what we call the hormonal hierarchy. People can come in with imbalances in all three. And when you don't know where to start, you start with the adrenal. Now, as with everything I said, there are exceptions. So if somebody comes in with a TSH of 35, don't give them herbs for their adrenals. We really are practicing good medicine, and I would say excellent medicine. And what we're talking about is an approach to evaluating dysfunction and imbalance in the body. And that does not mean no medicine, no hormones, no surgery. So what I'm saying is when somebody comes in and clearly needs thyroid hormone yesterday, you give it. Or if somebody comes in with horrible, horrible hot flashes, can't sleep, can't work, is just on a misery index of 1 to 100 is 150, start off with some hormones just to get things in balance as long as there are no contraindications. So we start with this hierarchy and we realize that there are exceptions. And then it's about looking for what we call points of leverage. So points or leverage means how do we change production, transport, synthesis, or detoxification through identifying imbalances and addressing them. Or, for example, if we know that there's a problem, with SHBG, for someone that has hormone excess symptoms, we'll address SHBG and raising SHBG, or the gut, because maybe the gut's causing inflammation. So inflammation would be a point of leverage, gut would be a point of leverage. So finding these ATMs. And then when we have the point of leverage, we push ever so gently. And what the push means is making changes. So reducing stress, eating a better diet, connecting with friends, whatever it is, we find the points of leverage that not only make sense intellectually and academically, but that the patient wants to do. So it's about putting on this, what I'll call the coaching hat, and saying, okay, here are 4 or 5 ways that we can start to change your hormonal issues. What would you like to do first? And maybe if there's some really major things, say pick 2. Do you think you can do 2 things at once? And what would those 2 things be? So it's all about having a conversation. And so what can we do to affect that hormone, and have we done everything? So before we give hormone, or normally before we give any drug, or before we do any surgery, have we done everything we can? And for hormones, that's PTSD. That's how we think about our treatment strategy. Transport or production, transport, sensitivity, detoxification, and excretion. And this can be done at the same time you've got a patient with a TSH of 40. You're doing everything at the same time. So we want to look at production because we can naturally increase production if we give the right nutrients. Remember I said zinc is important for testosterone production, for example. So let's remedy a zinc deficiency if we're talking about low T. Transport, sex hormone binding globulin. Again, someone with fibroids or breast cancer. Low SHBG. Let's talk about a low-fat vegetarian diet and normalizing body weight as a way to increase SHBG. Sensitivity. We talked about insulin resistance and rigid cell membranes. I showed you about cortisol receptors when there's too much cortisol around. So let's increase cortisol sensitivity by decreasing cortisol production. How do we decrease cortisol production? You'll learn about that later, but we'll be reducing stress and phosphatidylserine. Detoxification. Let's say somebody has constipation. Well, estrogen is eliminated in both urine and stool, but primarily in stool. So if they're constipated, they're at risk for taking the estrogen out of their stool and reabsorbing it. We call that enterohepatic recirculation. So let's make sure that our patients aren't constipated. I mean, when I started learning this and then asking about it, I'm like, oh my God, I just must be attracting constipated patients. And I can't tell you, number one, how common it is, as you all know, but how important it is to address that, as well as microbiome issues for estrogen. So production, the building blocks. Do we have enough of the building blocks? What causes secretion of insulin? Maybe we have too much androgen, and that's causing too much insulin or too much visceral adipose tissue. How about autoimmune disease and treating the gut? How does insulin impact transport of estrogen or testosterone? I told you, insulin will lower sex hormone binding globulin. That's the reason women with type 2 diabetes or insulin resistance have more breast cancer. Not only do they have more breast cancer, but they, unfortunately, have increased risk of recurrence and increased mortality. In fact, there's a paper out there that says, check a fasting insulin level. It's the time of diagnosis of breast cancer, and if your patient has an elevated level, additional treatment other than conventional oncology treatment is required. That's from Pam Goodwin at University of Toronto. Really important paper. So does a hormone transport from its gland impact its effectiveness? Of course it does. And how do we impact the level of free hormone? Through changing sex hormone binding globulin. And how about T4 to T3 and reverse T3? Many of you probably haven't thought of testing reverse T3 ever. Well, reverse T3 is a thyroid break. So you're going to learn how one of the causes of your patient's low thyroid may be that it's the high reverse T3. And Dr. Luby is going to talk about how to tweak that and adjust that. So what are the factors that influence cellular response? We're going to talk about this in each of our sections. We talked about cortisol resistance and thyroid hormone resistance. They are real. Detoxification. Again, metabolizing, digesting, eliminating our estrogens in healthy or unhealthy ways. And it's totally changeable. And what do we do? How do we do that? How do we enhance excretion of estrogen? I told you, getting rid of constipation, and then also making sure the microbiome is right, because the microbiome affects those, not only the total amount, because there's enzymes there from bad bacteria that makes you reabsorb more estrogen, but then it also changes whether you metabolize through a healthy or an unhealthy pathway. So PTSD, production or synthesis, transport, conversion, sensitivity, and how we eliminate. So when you have a patient and you suspect or they tell you they have a hormone issue, you're thinking PTSD. You're thinking about normalizing the matrix, you're thinking about PTSD, and then you're thinking of that hierarchy of adrenal, thyroid, and sex hormones. That's really the functional medicine approach here. And I've had patients come in with estrogen excess symptoms, and I have them look at their makeup, and they're like, oh my God, like everything I'm using is the highest amount of foreign estrogens. So it is very complicated, and I really hope I've given you some tools to understand how to make it less complicated. Study this, how all the different nodes affect hormones and how hormones affect the other nodes. So, 54-year-old man presents with low energy, mild central adiposity, decreased libido, gained 10 pounds. His job is somewhat stressful. And what I'd like you to do is just take a couple of minutes with your partners and talk about what you think is going on here from PTSD. Initial lab testing is normal CBC, a little bit of cholesterol, but basically low normal T. And what would you do? So basically, when we're looking at this case, it's how do we stop the conversion of testosterone to estrogen or testosterone to DHT. And you're going to learn more about this later today. So these are just teasers, right? So what would you do? And basically what you want to do is stop the conversion of testosterone either to estrogen or DHT. And so that involves the use of nutraceuticals to block DHT. Now, parenthetically, DHT can cause hair loss. And so there are blends of DHT blockers. So look at these, start to become familiar with them. You're going to hear more about them later today with Wendy Warner and Mark Holthouse talking about them. And, you know, for example, and then you'll find that there's some combos like stinging nettles and soy are with both. And these are gentle ways to use our points of leverage to give a little gentle push. In your toolkit, you have 5-alpha reductase inhibitor lists and aromatase inhibitor lists. And you hand these out to your patients. They explain what's going on, and you tell them what you're giving them. So PTSD, this is what you go back to. The goal is balance. Your job is to help them promote balance in their lives in whichever way you can, want, or desire to do that, and how they want to engage you in that process. But at least you have to point them in that direction about the importance of balance in their lives and balance in the matrix. Because hormones are all about balance, and what I will tell you is that you will be better able to help your patients achieve balance, both in their lives and in their matrix, if you work on achieving balance in your life and in your matrix. Because a physician that has confronted the issues of achieving balance, both in their life and in their matrix, is better able to transfer